And I'm also not talking about a very uplifting subject either. So we're going to be talking about suicide and suicide prevention. So just a little bit in terms of why I'm so passionate about doing this work is that, so I am a clinical social worker, and I started work at Joburg Child Welfare, but then I worked for Lifeline for about 9 years. And I was very conscious of the fact that in South Africa, Lifeline and SADAG, the South African Depression and Anxiety Group, are probably the only two organizations that would say that they work with suicide. At that time, I wasn't sure that we were doing enough. I wasn't sure that even as a nation, that our mental health and that suicide prevention was getting enough attention. So I then went and did another master's, and I wanted to focus on suicide and suicide prevention. I also, in 2001, lost my mom, and after that I remember just always being so ragingly angry. I was angry at God, I was angry at the world, I was just angry with absolutely everybody. And it was only after a while that I actually realized, you know what, I'm actually depressed. I think that's what one of the speakers said today, that, you know, depression could present as irritability, but I was so angry all the time. And I then started to develop suicidal thoughts. And I never acted on it, I never attempted, but it was part of my reality. So I also could then identify with the people that I was then working with. And it's such an issue for me in terms of the fact that if you talk to some, and I've had conversations with professionals, whether it's psychologists, registered counselors, social workers, that people say, oh, well, I don't work with suicide. And for me, that we are either in denial or we are naive to think that the person walking through my door is not going to present with suicidal thoughts or with ideation. And so I also am aware that our universities are not equipping people well enough to be able to deal with suicide and to be able to put in a treatment program and to do an assessment and to do enough work around suicide prevention and identifying when someone is at risk of suicide. So that is why I am passionate about this topic. I'm passionate about this work. I am in private practice, but any opportunity to train and to equip people to be able to identify when a person may be at risk of suicide and how to motivate them to and guide them in the right direction to get support, I'm there. Okay. So just think for a second, when you hear the word suicide, what comes to mind? So just take a second. Just remember to breathe. Now just think about, when you think of suicide, what's the word that comes to mind? Loss of purpose. Okay. Giving up. Yeah. Say again. Solution. So suicide is the solution. It's an option. Yes. Okay. Anything else? What do you think of when you think of the word suicide? Self-harm? Hopeless. Just make the pain stop, yes? Okay. So we also have to be very conscious as professionals in the mental health field about how I perceive suicide. Because if I perceive suicide as being a selfish act, or someone is searching or looking for attention, or is manipulating, then I'm going to be very different in treating that person than if my perception is that this person is in the depths of despair and that they're self-loathing, they're angry with themselves. There's this emotional pain that is so overwhelming. They feel helpless and hopeless. It's a very different place in terms of how I will then approach that client if I see it in that way. Okay, so let's have a look first at, obviously just getting on the same page, let's understand what suicide is. So it is the deliberate, intentional taking of one's own life. Parasuicide behavior is the apparent attempt at suicide without the intention of killing yourself. The problem is that our hospitals are filled with people who may not have intended to kill themselves, but that they end up injuring themselves, or we might even have people who, it was just my intention to kind of injure myself, and I then accidentally die. Okay, so, and I think our hospitals, that's most of the suicides that come into our hospital, they kind of see it as a parasuicide, and we're not treating it with the intensity, the seriousness that we need to. Remember, when someone has attempted suicide, they are high risk for attempting again. So we have to always take suicide seriously. So also, it's not the suicidal thoughts that is genetic or where there is a predisposition for. It's the underlying potential psychiatric condition, the depression. But we have to bear in mind that, if you do a history or you take a history with a family, they would then be able to say to you, well, I know my mom is depressed. I know that my uncle attempted suicide. So we need to also be aware that the person that's sitting with us could potentially be predisposed to depression and then suicidality. Remember that not everybody who is struggling with depression has suicidal thoughts. Okay? So it's, your depression can present in a way that doesn't present with suicidality. But it is the most common psychiatric condition that the hospitals are dealing with, is suicide attempts and underlying mood disorders, which is then depression. What is our core skill as practitioners? It is the most important thing for us to do is to be able to assess whether a person is at risk of suicide. Are they high risk, medium risk, low risk? And the professor this morning spoke about one of the assessment tools. There are multiple different assessment tools online that you can use, but we have to, our skill as a therapist, as a practitioner, is assessing suicide risk. That's the core focus in the work with suicide. And then it determines how we're going to treat this patient. What does our management of the case look like? And it could range from drastic intervention, which could be hospitalization in a psychiatric facility, or it could be arranging for support for that individual. So as mental health professionals, we are concerned also with the day-to-day challenges of understanding the genesis of suicide, and then detecting suicidal ideation, which is the assessment process, determining who is high risk for suicide, and then treating the psychiatric conditions most commonly associated with suicide, such as major depressive disorder. Remember also that suicide, there doesn't always have to be a psychiatric condition. In fact, you've probably heard or you've read literature that says 90% of people who struggle with suicidal thoughts have a psychiatric condition. That has never been proven. There's no evidence to show that. In fact, there are many other kind of social, environmental factors that kind of push us into that space of having suicidal thoughts. And we can just look at that in terms of COVID and how that has impacted our mental health. So not all suicides are a consequence of psychopathology, which I've said. Suicidal people are not selfish. They're not seeking attention. They're not manipulative. They're not indifferent to the feelings of others. So sometimes we work with the survivors. We work with the people who are left behind. And of course, the devastation that that person is going through, having lost a family member or someone close to them to suicide, is overwhelming. The healing process is a very complicated, very difficult process that they have that they have to maneuver through. And in fact, that was my research. My research was working with moms who had lost a child to suicide. And everybody's kind of process of healing was very different, but healing, the end result was living life differently, but definitely not completely healing from the loss of that child. So the suicidal person is burdened by the darkest, most painful of thoughts, and often by corrosive self-loathing. So suicide is not about wanting to die. That's not what my thoughts are and that consume me. It's about, I just want the pain that I feel to end. So, people say, well, how could my child not have come and spoken to me? How could they not have just, thought about the impact of their death on me? The reality is that when you're in that space and you're in that dark, dark pit, you actually believe that you are doing the people around you a favor. I'm a burden. I need to let them go because I am just so overwhelmed with my pain. So our task is to comfort those afflicted and not to condemn suicide. Victoria spoke about stigma, and I think this is probably one of the mental health areas that endures the highest level of stigma, based on the fact that we're working with life and death. There's no coming back from suicide. So, there's treatment programs for substance abuse, there's treatment programs for anxiety, depression. But if my option is eventually suicide, there is no coming back from there. So suicide rates seem unaffected by the efforts at reduction. So every country is, you can Google suicide prevention in every country, and they've got multiple suicide prevention programs. But the risk and the prevalence of suicide is not reducing. So it doesn't matter, it doesn't seem to be that the more we do towards suicide prevention, that actually the rate is decreasing. And there's also moral implications in terms of our own ethical considerations that we have to bear in mind. People sit in judgment of suicide. Is it right? Is it immoral? And so we have to suspend our own judgments when it comes to suicide. So interrogate and understand our own assumptions and our own moral stance. Okay. So that's important for us to think about me and what is it that I think about suicide, and that will guide and limit our understanding. Like I was saying earlier, if I'm a professional, if I'm a social worker and I'm in private practice and I say I don't deal with suicidal cases, the reality is that I'm probably not going to hear when someone is suicidal. Because it just, I'm missing it, I'm dismissing it, I'm avoiding it. But I have to, in terms of being responsible for the people that walk into my practice, I have to very consciously make sure that I'm equipped to be able to deal with suicidal individuals. So what are our global statistics? So in the time that I'm going to be talking now for 45 minutes, internationally, globally, 68 people will die to suicide. So 1 million have completed suicides globally. This is pre-COVID stats. So one person dies every 40 seconds. Suicide is the second leading cause of death amongst 15 to 29-year-olds, and that is males. So it's the second leading cause of death globally for our male population between 15 and 29. And 75% of global suicides occur in low and middle income countries. And most of the ways in which suicide takes place would be ingestion of pesticide, hanging, firearms are among the most common methods globally. I think what our young people nowadays are finding is that, I think it's called haliprimi, where they are able to access rat poison very, very readily in their communities. And that's what people are now ingesting in order to kill themselves. So it is an effective way of suicide. So every suicide is obviously a tragedy that has multiple layers of impact. So it's not only that individual, but it's their family, and then it's their environment and their community. So, and like we're saying, the healing process for someone who's lost someone to suicide is very long and very difficult. It's a very difficult, complicated grieving process. And the sad reality is that suicide has been at a level of prevalence that has been in a state of crisis for a long time globally and is still moving in the wrong direction. So our stats are still climbing. And I think we can see that even more so now with COVID. So over the last 20 years, suicide rates have risen by over 35%. And there's much global scientific research into what drives suicide risk, but also what can prevent suicide. So there's an awareness around what are people experiencing, what is happening for people that they get to that place where suicide is an option. But even though we put suicide prevention into play, it doesn't always necessarily mean that the rate is going to decrease. But suicides are preventable with timely, evidence-based, and often low-cost interventions. Remember that only 5% of our national mental health budget of our health budget is for mental health. And if that's even then kind of cut even more to deal with suicide, there isn't enough money that is going into suicide prevention in our country specifically. And I think a lot of it also has to do with the stigma. There's still people who go to hospitals and are in a depressed and or suicidal place, and they are told, you wait there and you sit and wait for the resource to be available for you because there are other people here who want to live and you don't. So and that's still happening in our communities. So what is our South African statistics? So in South Africa, 1 person dies every hour. These stats are pretty old as well. So I'm sure that this is, firstly, it was even probably higher than this, but there isn't any kind of relevant research that is being done or put out there in terms of our statistics. So if we're looking at, in a year, 8,400 people are dying by suicide. And again, in South Africa, males between the ages of 15 and 35 are the highest risk. Why do you think our males are highest risk? Why would you say? What would you think these? Yeah?
Hello. Oh. So we actually talked about it yesterday. Me being a black man, we're not taught, or it's not normalized to express what you feel. Sometimes you keep it inside.
Yes.
Up until it gets to a point where it blows up in your face. So that's what I think.
That is one of the core issues in terms of, and especially in South Africa, is that there's certain expectations of men and then of families that we don't talk about these things. So that's part of our suicide prevention strategies that we have to put in place. We have to be able to talk about suicide, talk about the fact that I am in that negative space, which is what Khamotso was saying. People don't always embrace us when we come with our mental health issues. Whereas if I broke my leg, it wouldn't be a problem, okay? But one of the reasons that men are more successful at completing a suicide is that they use much more volatile means. So a guy would probably shoot himself or hang himself, whereas girls would take an overdose, and then the rate of surviving an overdose is much higher than for the males. But what we also know is that for every man who dies by suicide, 4 girls have attempted. Remember, women are also more prone to depression. So we are at greater risk for depression, suicidal thoughts, but when a man makes that decision, he's serious. He's going to end his life. The third highest cause is suicide, is the third highest cause of death in South Africa. And that's after homicide or murder and then vehicle car accidents. That's obviously not including our disease-related, so we're not looking at heart conditions or cancer, but it's our third highest cause of death. But for every completed suicide, now can you hear I'm using the word complete suicide, not commit suicide? Okay, so for me, when we're looking at stigma again, it's about saying, if I say to you, you committed something, you committed a crime most often, it's always, there's a negative connotation. So we want to kind of remove that stigma to say that if you commit suicide, you are doing something wrong. Yes, suicide has been, you could be arrested years ago. It was criminalized in terms of, if you did attempt suicide, you could be arrested. There's still certain African countries that is still their truth. You can be arrested if you attempt suicide. So we have to remove that stigma as well. That it's not that that we're committing a crime. So we need to change our languaging as well in terms of being able to embrace suicide. So for every completed suicide, there are more than 20 attempts. Now, I think that statistic is also very low. I worked at Akiso at the psychiatric facility in Alberton. I worked as the young adult program manager, and I often found that the young people would say to me, I took an overdose, I went to bed, I woke up in the morning, I had to put on my uniform and go to school, and I didn't tell anybody. And I hear that over and over. I still work at another psychiatric clinic at Life Brackenview, and that is what I hear all the time. So our statistics, only the reported statistics are the ones that end up in hospital. But what about those ones where they are at home and also families don't want to take their children and or family members to hospital because of that fear of stigmatization? So we have to start to remove that, remembering then that if someone has attempted, the risk of them attempting again is very high. So 80% of us, so if we kind of look at this room, so this whole side of the room, at some point in our lives, we've had thoughts of suicide. You guys are safe. You haven't had thoughts of suicide. You're 20%. But all of us have been affected by suicide. All of us know someone who has died by suicide. We know, Robin Williams and well-known people who attempt suicide or have completed a suicide. So all of us are affected in our communities by suicide. So now we want to look at suicide in relation to COVID. Okay, so obviously we know we've been all been through a collective experience where there's been fear of the threat of the virus. There's been isolation and lockdown and not being able to see our grandparents and our parents, family members, not being able to get away, get out of our home, working from home. So all of this has had an emotional impact and a psychological impact on our mental health. There is no, I think if we have to look at COVID-19 as a mental health pandemic as well as an infectious disease pandemic, I think we're only now starting to see the mental health effects, because last year it was about physical survival. So it's like that hierarchy of needs where we first have to focus on our safety. And now we can start thinking, okay, but what's the impact that COVID has had on us? And what are we now? And I think it's exacerbated anxiety for children. I work at a school at the moment, and every one of the children that I saw was absolutely debilitated by anxiety by the time they had to write their exams at the end of last year. So, we can't underestimate the impact that COVID has had on our mental health. There's no research right now that will give us numbers or statistics in terms of how the suicide rates have increased now during the pandemic, although I am of the firm belief that when we do this research, our statistics are going to be through the roof. So not just 23 suicides in a day, we are going to have a very high percentage of suicides. Minister Mkhize said that 1,781 suicide-related deaths occurred under lockdown between 27th of March and the 27th of July. And other spokesperson for security companies, CERT SA, the emergency services, every one of them have reported that they have had an increase in suicidal calls since the beginning of lockdown. And many of the deaths from their statistics have been males between the ages of 40 and 50 years of age. I think that also has a lot to do with the fact that with COVID, lots of people lost their jobs. As a man, what is my self-worth comes in what I do in my job. For us women, our self-worth more often comes in our relationships. So it's an emotional connection that's important for us. So 40 to 50, I'm responsible for my family and providing for my family, and that has been negatively impacted. And most of these suicides were shootings, hangings, and overdoses. So calls from people who are suicidal or struggling with depression or anxiety, all of our call centers nationally also increased. They almost doubled in terms of the number of calls that presented to our call centers. Internationally, the director of the CDC, the Center for Disease Control, indicated that more youth are dying of suicide and drug overdose than COVID-19 during this pandemic. And we know that, yes, COVID did target older people, people with comorbidities in terms of death, but suicide was in the result for our young people. So the contributing factors, obviously, and this list can go on and on and on, and we all have our own personal experience of the impact of the pandemic. But there's definitely been a development of depressive symptoms, panic, fear, elevated anxiety due to the financial burdens and uncertainty, lots of life changes, level of uncertainty about the threat presented. So a lot of unknown
5
about...
minutes, Lorraine.
No, you're wrong. Seriously. Okay. Isolation, feeling lonely, and a loss of a sense of belonging. Okay, so oops, now I went and messed it up. There. Okay. All right, so all of those we are very aware of in terms of the impact. So the ultimate impact of the virus, mental toll, according to some experts, will present itself in our country statistic, in our suicide rates in 2020 and beyond. Okay, what do I want? But there's also been some hopeful thoughts about suicide and mental health. So there's been a global sense of community, a kind of bringing together, a cohesion that we're all experiencing. We're not alone in our struggles and in our pain. There's a sense of that togetherness, and that connection is life-saving. Remember that depression, one of the underlying core issues is no sense of belonging, and I feel like I'm a burden. So that connection is also life-saving in some ways. That our previous reality was one in which, talking about suicide was stigmatized. We didn't do that. Now we're all basically talking about our changes in mood and anxiety and trauma, and it's normalized the dialogue. Okay, we have to be talking more about depression and suicide. Telehealth care has begun to revolutionize mental health care as well. So with COVID, then we started with Zoom therapy sessions, and I think that that's something that's going to stay for a long period of time. Can we just watch this video? And then, because what we want to be looking at is how do we identify when someone is at risk of suicide. Now, this was an interview that Meghan Markle did in 2019, and when I watched it, I remember thinking that she's not okay, that she has suicidal thoughts. And I know I probably hear suicide in everyone's conversation because I'm so attuned to it. But just listen to this, to her story quickly.
Perhaps you could just give us an idea of what the last year has been like. I guess that's a where would you start question, but give it a go.
It's hard. I don't think anybody could understand that. But in all fairness, I I had no idea, which probably sounds difficult to understand here, but when I first met my now husband, my friends were really happy because I was so happy, but my British friends said to me, I'm sure he's great, but you shouldn't do it because the British tabloids will destroy your life. And I very naively, I'm American, we don't have that there. What are you talking about? That doesn't make any sense. I'm not in tabloids. I didn't get it. So it's been complicated. I've said for a long time to H, that's what I call him.
Yeah.
It's not enough to just survive something, right? Like, that's not the point of life. You've got to thrive, you've got to feel happy, and I think I really tried to adopt this British sensibility of a stiff upper lip.
It has its, advantages, I guess.
I really tried, but I think that what that does internally is probably really damaging, and the biggest thing that I know is that I never thought that this would be easy, but I thought it would be fair. And that's the part that's really hard to reconcile. But I don't know, just to take each day as it comes.
Okay, so generally, what we have to focus in on when we're listening for suicide is, what do I see? What do I hear? What are the underlying life events that this person is experiencing? And what are they saying? What are we hearing? What is their emotional response? And if we look at Megan, we know that her life changed drastically. So her life event, she moved from the USA to the UK. She was an actress to a princess. Marriage watched by the world. Loss of career, loss of identity, loss of independence, constant scrutiny, adjustment to very formal, rigid system, perceived racist reports in the tabloids, bullying by the media, loss of relationship with family members, struggle with and betrayal by her father, or perceived betrayal, shaken belief in self, pregnant, she had a newborn baby, adjustment to constantly being in the public domain. So we know that that was her experience. And what we hear in that interview was, firstly, the hesitation and sigh when asked, how has this last year been? She couldn't verbalize initially. She was saying it's been hard, really hard. It's not enough to just survive, right? We have to be happy, we have to thrive. So she's thinking about life and death. We know that that's in her head. It's about living and versus surviving. I really tried. I hear that in all the people that I work with. I'm tired, I'm just trying to just keep through every day. Adopting that stiff upper lip, which is very damaging inside. She's talking about the negative impact on her emotion. She's saying that her friends told her they're going to destroy your life. So again, she's talking about life and death. I never thought it would be easy, but I just did think it was fair. So very much that comes with shame. You know, like, they're targeting me, why me? What's that about? But we just take each day as it comes. I can't actually think about tomorrow. I can just think about the moment, each moment. Being pregnant, you're vulnerable, she says. I'm tired. And then in a later interview, she says, thank you for asking if I'm okay. No one asks if I'm okay. Can I guess? He says, can I guess that you are not really okay? It really has been a struggle, and she says yes. Now, if we were doing our suicide prevention well enough, people in the UK at that point in time would have had acknowledged or identified she's not okay. But that was never done. In fact, her interview now with Oprah she told us that she is now, she'd gone to HR at the White House is America, at the palace, and they had basically said, well, actually, you can't go and get help for your suicidal thoughts, because what will it say about the institution, about the monarchy? So, and then what are we sensing? Her sadness. You've got to thrive. You've got to feel happy. So obviously, she's not feeling happy. She's sad. And the fragility, you're not okay, are you? When, the vulnerability that she felt when she was pregnant. Shame, I thought it would be fair. Regret, friends warned me that tabloids would destroy me. The resignation, just take each day as it comes. Helpless, anger, despair, damaged inside, hopeless, I'm really tired. And then what do we see? We see the sadness, we see her fragility, we see her vulnerability, or low energy, hesitation, loss of confidence, tiredness, and withdrawal. So if people had watched that video, they would have acknowledged that she has, you know, if we are aware enough about suicide, we have to then ask the people around us. So once we identify all of this, what do I see? What do I hear? What do I sense? What are the life events that potentially could be challenging this person? Then I need to take some responsibility to say, so I'm concerned about you, and I'm seeing this, and I'm hearing this, and your life events look like this. Are you thinking about suicide? That's one of the techniques in terms of suicide prevention. I'm not going to watch the video. I just want to quickly say, we suck at suicide prevention. We've said that already. We haven't brought down the death rate to suicide. We're making great strides in terms of cancer and heart disease. HIV is managed, but we are going in the opposite direction in terms of suicide. Why? What's happening? We need to be more aggressive with our suicide prevention strategies. Every facility needs to be aware of how to identify when someone is suicidal. Nobody just comes up, or very few people actually just come up to us and say, I'm having suicidal thoughts. There's a much more subtle way in which we have to hear those thoughts. So how do we then prevent suicide? We need to eliminate the myths. We need to make sure that the person doesn't have the means. If my thought was I'm going to take an overdose, we need to remove the means. That they would, we need to encourage people to talk and to get help. We need to identify suicide risk very early so that we can get them the help. We have to assess well enough so that that person, we know that they are high risk or low risk. And inform family members. So many of the people come to me and say, if I tell you this, will you keep it from my family? We can't in terms of our ethical code and confidentiality. We have to be able to say, actually, when it comes to you being a threat to yourself or to someone else, I cannot collude with that secret. I can't keep that from family or friends. But it is a process in terms of finding the right people to then bring alongside that person who is suicidal. Okay, I think we have basically covered the training for professionals. We have to do more training in terms of how to manage and understand suicide and treat suicide and create meaningful, supportive, safe, therapeutic relationships with our clients. Okay, thank you.
Thank you, Lorraine.
Look, I was really ashamed to say it at the time.
Okay.
And ashamed to have to admit it to Harry, especially, because I know how much loss he suffered. But I knew that if I didn't say it, that I would do it. And I just didn't want to be alive anymore.